Good afternoon. First, I'd like to thank the team at MPAF for inviting me to speak today. My name is Katherine Gallagher. I'm the VP of Health Services Research at Patient Advocate Foundation. And as Alan mentioned, I'm going to be doing a data spotlight on our rural patients served by our case management team in 2019. And I'm also going to share with you some of our recent survey highlights, specifically looking at our rural population. So just as a little bit of an introduction, approximately 7 million people, or 29% of the United States population, live in rural or remote areas. We know that there's significant differences in healthcare access between rural and urban areas. Many of the patients in rural communities are at a disadvantage when seeking healthcare services. Specifically, specialty services, distance to travel, reliable internet, and cell coverage are often barriers to their care. Also, reluctance to seek healthcare in rural areas can also be based on cultural and financial constraints. So, Patient Advocate Foundation provides diverse case management services to patients with over 600 different chronic illnesses. We provide telephone-based financial and social needs navigation services, and these are often one of the most reliable methods to assist patients in rural populations to address barriers to care. In 2019, the case management team served just over 2,500 rural patients, and this was approximately 17% of the total population served. So geographically, where are our rural patients located? So as you can see from the density map, the vast majority of the rural patients that we served in 2019 are along the southern and eastern part of the United States. But like their rural counterparts, most of our urban and suburban case management patients are also located in these areas, specifically the South, which is about 50% of the individuals that we assessed. Our partners, our programs, and our research activities contribute to the makeup of our case management population, and this does explain the higher concentration of patients served along the Eastern Seaboard. However, our education, advocacy, and health equity teams are working towards increasing engagement with rural patients, providers, and community groups to help them improve their knowledge about PAF as well as our resources. So what do our rural case management patients look like? Approximately 39% of patients served are male, 61 female. We served approximately 6% Hispanic, 16% African American, but the predominant rural patient that we serve is Caucasian. 15% of them were uninsured in 2019. The vast majority are over the age of 56, with 31% being retired and 31% reporting that they were disabled. And not surprisingly, 85% of the individuals we assisted in rural communities had a household income less than $48,000 per year. However, most of the demographic characteristics that we see in our rural population were actually similar to our urban and suburban patients. Although the slight differences are that our rural patients are more likely to be male, Caucasian, older than their urban or suburban counterparts. So what were the issues that our patients in their rural communities came to us with? Well, the top 5 were transportation, pharmaceutical copay, doctor visit copay, rental assistance, and utility assistance. The top 5 issues that are reported by all case management patients are actually the same regardless of location. However, the order in which this assistance was requested for the 5 different items varied across the 3 groups. As you saw on the previous slide, rural communities, transportation was their #1 need, whereas utility assistance was the #1 need for urban patients. One of the other things that our case management team does is to work on behalf of the patient to obtain debt relief for them. So in 2019, you can see that across all of our patients, we acquired almost $12 million. If you look at that by our rural, suburban, and urban patients, you can see the dollar amounts, as well as you can see the percent of the total debt relief that went to patients in those areas. Not surprisingly, the rural communities saw a much lower percentage of the debt relief, but when you actually look and compare it to the percentage of our case management caseload, it's actually not as unequitable as one would assume. To better put this in perspective, we actually decided to look at the average debt relief obtained per patient. So the blue bars look at the total debt relief divided by the number of patients for all of the debt relief acquired. As you can see, our rural patients, the debt relief per patient is lower than what you would see in our urban populations. To get a better grasp, we actually excluded all of the individual patients who had debt relief obtained for them over 50,000. And as you can see in the yellow bars, this actually brings the delta much closer on a per patient debt relief obtained. And this is because in our rural communities, we only had 6 individuals with debt relief over 50,000. We had 16 and 19 in the urban and suburban. Now I'm going to switch gears just a little bit to actually give you some insight into a couple of surveys that we conducted in 2019 and 2020. The first survey statistic I'm going to share with you was from our retrospective survey. This particular survey was done in January of 2019, and we actually asked our patients questions in multiple distinct domains. One of the ones I wanted to share with you was a promise measure, which is about physical health. So we asked patients how they felt that their physical health was in the last week. And as you can see, our rural patients had a much lower response for excellent or very good, as opposed to their suburban and urban counterparts. In fact, they were almost 2 to 3 times less likely to report high levels of health. Another measure that we wanted to capture was just asking patients about general distress. So this is just general distress, not financial distress. So patients answered on a 0 to 10 scale. And as you can see in gray, rural patients were more likely to experience higher levels of distress in the 7 days prior to taking our survey than their suburban and urban counterparts. The second survey that we did in October of 2019 was around the impact of their chronic disease diagnosis on their ability to work. So looking at their time of diagnosis, we can see that our rural patients were more likely to be retired or disabled at the time of their diagnosis and to be diagnosed at an older age than their urban counterparts. So it's important to think about this because the next series of questions we asked them was about the amount of time that they needed to take off during treatment. So when we asked, for those who were employed, did you take time off? You can see that our rural population answered almost twice as much as our other populations in terms of needing to take time off. When we asked how much time they took off, you can see that although for most of the 4 to 6 month, 2 to 3 month, 1 month, 1 to 3 week, and 1 to 7 days, the answers were very similar. You can see that when it was more than 6 months, our rural patients were needing to take more time. The next question we asked in this work impact survey was around physician conversations. Specifically, did your doctor have a conversation with you about the impact of treatment on your ability to work? And as you can see, this conversation happened with more frequency with our rural patients than with our suburban and urban. The last survey that I'm going to talk about was the COVID-19 Pandemic Impact Survey, and this is one that we launched in June and May of this past year. And specifically, I'm going to share with you some of the statistics we have around access to care and telehealth. So we asked our patients, have you changed the way that you access care, or have you changed how or where you receive it? And as you can see in the red box, our rural patients were more likely to delay care, and they were also more likely to indicate that they were using telehealth options. When asked how many telehealth visits they've had since the beginning of the COVID-19 pandemic, interestingly enough, our urban patients were more likely to report a higher number of telehealth visits. And this actually may be in response to when we asked patients about concerns using telehealth or barriers to using telehealth. We can see that our rural patients were almost twice as likely to have issues with internet, data, and cellular services than their urban counterparts. And this could have impacted their ability to actually conduct or receive a telehealth visit. So there are a few limitations to the data that I've shared with you today. So currently, right now, our location data are self-reported, and it's actually only captured in our case management and survey questionnaires. However, we're currently exploring the use of geolocation data, which are referred to as RUCA and ADI codes, to allow us to utilize addresses and 9-digit zip code information across all of our PAF service silos. For the survey components, those are administered via email, which means that they would require web access or cellular data to complete. Lastly, confounding factors in our survey data were not controlled in the presented stratifications. So other factors such as demographics or a diagnosis may also be influencing the differences seen between the two location groups. We're currently working with multiple academic partners to conduct formal statistical analyses of our survey data, including the use of RUCA and ADI codes to address location and other research questions. So in summary, case management patients served by PAF are a fairly homogeneous group regardless of location. Although the top issue for rural patients was transportation, their top 5 issues are identical to those sought by their urban and rural counterparts. Rural patients reported poorer physical health and higher levels of general distress than their rural and urban counterparts, and rural patients were more likely to be disabled or retired when diagnosed and to take more time off for treatment. Higher levels of rural employed patients indicated that their physician discussed treatment impact on their workability, and this is also probably related to the potential for them to need to travel farther distances for care. And rural patients were more likely to delay care and use telehealth options. However, they also reported twice as many issues with internet, data, and cellular services. I'd like to close out this presentation with sharing from our cost of care focus group a quote from one of our participants. "We are an economically oppressed, underserved area. There's not a whole lot of draw here or incentives for providers to come here unless you're from here. It's beautiful, but it's very remote, very rugged. They have had a hard time getting providers here, so there hasn't been that continuity of care that the people here really deserve." I'd like to thank everybody for their time today. As Gwen mentioned earlier, please enter questions about today's presentation into the chat function in Zoom, and Jamie will be monitoring and moderating the chat to read viewer questions. I'd also like to acknowledge my colleagues, Rebecca Angove and Eric Anderson, for their support with this project and this presentation. Thank you.
Thank you, Kate. All right, I'm going to go through some of the questions. There's been heavy dialogue during your presentation, really good comments. One question that was sent privately to me Do you have data on the impact of hospitals closing in rural areas?
So, Jamie, it's an interesting question. As of right now, we don't, but because we are increasing our capacity to be able to use geolocation data, that is something that we could potentially look at. So we could look in a particular area at patients that we've served and look to see have different hospitals closed in that area, or we could actually look to see what do they report as their distance travel to care, and then we'd be able to map that.
Great, thank you. Another question from Tracy in the chat box came. Why do you think doctors talked with rural patients more about taking time off from work?
Based off of everything that I've heard today, and my own gut instinct, I would guess it's because probably that patient will need to travel farther for care, or will need to get care that's not in their immediate community.
Okay, and another question from Dicey Scroggins. Hello, Mary. In terms of telehealth, could you say a little about the satisfaction level with or patient feelings relative to in-person versus telehealth services?
Yeah, so we did ask a couple of questions around satisfaction with telehealth services in our initial COVID survey, and if I remember correctly, I did not stratify it by location, but across all of our participants, it was between 70 and 80% were satisfied with the telehealth services that they'd received.
Okay. And the next question from Kate O'Reilly. Can you tell me which distress scale you use to measure the distress levels?
Yes, it was the NCCN General Distress Thermometer.
Great. And from Greg, have you used the National Core Indicators data as it applies to individuals with disabilities and older adults?
We have not reviewed, looked at, or used that tool.
Okay. Another follow-up question, is distress exhibited in the same way across populations? If not, how do we compare those levels?
We've looked at the distress results across several different subpopulations, and generally it just kind of depends on what we're trying to compare. We did use the distress thermometer for a pre and post case management intervention study, and we did see that general distress did decrease after patients had interacted with our case managers, as well as we saw that general distress also decreased after patients were linked to other financial resources that Patient Advocate Foundation provides.
Great, and I think there's one more. Is there a way for Wi-Fi devices? Okay, I'm sorry. Is there a way to, I guess, get Wi-Fi to underserved people or families? I know with education they do and provide buses with hotspots here in North Carolina.
To date, I don't know of any specific projects that we've been involved in. I've definitely heard anecdotally from different health professionals in different communities of how they've been trying to help patients who are in need of having access to a hotspot to be able to do a telehealth visit. So, for example, I recently attended the APHA conference, and they mentioned that there were several coffee shops, restaurants, bookstores. They actually boosted their their free Wi-Fi signals so patients could actually sit in their parking lots in the privacy of their cars to be able to do a telehealth visit either with a laptop, a tablet, or their phone, and to have access to Wi-Fi.
Great. And another follow-up from Lisa. Did you use NCCN checklists for specific forms of distress?
So when we used the general distress thermometer in the pre and the post, we did include the checklist. With that, there were a few items that we did not include because they would not be applicable to the population that we serve. But we have not actually taken the thermometer results for that separate survey and looked at it or stratified it by the checklist.
Great. And from Aurora, is this research available online for sharing?
There's definitely elements of some of these surveys that have been made publicly available. As of right now, because we are working closely with a couple of academic partners on doing some in-depth analyses, we're waiting until those activities are completed and we do our due diligence of publishing in peer-reviewed journals with them. So.
Great. And another one from Mary. Did you find that the lack of engagement in telehealth, telemedicine might relate to bandwidth or lack of knowledge about its availability? Do patients commonly know about telehealth and how to use or engage with it?
So in our COVID survey, we did ask some additional questions around patients' uh, comfortability with using telehealth. So whether or not they felt like that they had the skill set. Um, we did not ask a specific question around whether or not they knew about telehealth. But a good percentage of the patients that participated, at least in our survey, indicated that they'd had at least one telehealth visit during COVID. So my assumption would be that many were familiar with that platform. But that's an excellent question and an excellent uh, point and something that we should look at including in any future surveys.
All right, I'm just monitoring to see if we get any additional questions.
Oh, Jamie, the last thing I also wanted to highlight, one of the other data elements that we captured with our telehealth was also recognizing that while telehealth can be the video experience that we're having right now, it can also be a telephonic experience. So we did ask patients whether or not they had phone only or the video interaction for those telehealth experiences.
Great. An interesting question from Jenna. Her parents were actually denied telehealth options and had to request it a few times from their physician during COVID-19. Do we think that physicians are also a barrier as well?
I think the fact that she experienced it as a barrier would be an indicator that not everybody is comfortable being on video. Many physicians may not feel comfortable providing advice where they're not actually in the same room as a patient. So, um, yeah, it probably can be a barrier in some areas. Yeah.
A question from Greg. Are any are any of your rural clinics, hospitals connected via telehealth with larger healthcare providers? If so, what does that look like?
I am not sure. Our patients who receive health in rural areas, I personally do not know who their specific providers are and what their providers' relationships may be with other academic institutions. I do know that we are partnering with the University of North Carolina at Chapel Hill to do a intervention study with them, and specifically PAF will be offering financial and social needs navigation to their rural patients to make sure that they are linked to those specific services, though not medical, still in a support function in terms of making sure that that holistic telehealth can be achieved.